Good morning, afternoon, and evening, wherever you are, and welcome to the latest edition of Free Thought Hour, the show where we interview interesting people. And we certainly have some interesting people to interview today. Firstly, my co-host, Tercia. Hello, and welcome to England.
Hiya. Does that sound Yorkshire-ish enough?
Yes. Welcome. I'm not sure about the accent, but welcome to the UK and the northern part of England. So
thank you.
I'm glad you safely made it here, and I'm sorry that you had a 2-hour delay or hold up in your journey. But I hope you've had a sufficiently restful time since and have recovered from the flight.
I have, and I've enjoyed every moment so far.
Great.
Yes, excellent. I love it. Yes.
Shall we introduce our special guest?
Please do.
Here he is, Scott Weigold. Welcome. How the devil are you?
I'm doing pretty well. Still recovering a little bit from a bout of COVID about 3 weeks ago, but otherwise, overall, doing very well. Thank you. And it's a distinct honor to be here.
Well, the honor's ours. And COVID does drag on a bit sometimes, doesn't it? I'm sorry you've had that. So you're a psychiatrist. I want to get that right because it's not a psychologist, is it? Can you tell our audience a bit about what the difference is?
Well, the most obvious difference that most people think of is that most psychologists cannot prescribe medications. Now, in some places they can. Mm-hmm. However, that's not really the biggest difference. Psychology is a study of thought and behavior that's really very far-reaching and normally does not focus tremendously on what goes wrong, but on normal thought and behavior. There are certainly those who do focus on what we call psychopathology or abnormal psychology. And certainly those who go into clinical work are focusing on abnormal psychology. But the psychology route is a traditional graduate school study where you are expected to master the thought and philosophy of that field.
Yeah.
Psychiatry is a medical specialty. And so rather than a traditional PhD graduate school, psychiatrists are going to medical school. Now, here in the United States, that's considered a graduate school, but it's not considered that in every part of the world. In some places, it's considered more of a vocational school. Now, I would actually argue that medical schools in the United States are a vocational school, and they are categorized as a graduate school primarily for the sake of funding and accreditation. But medical school is a how-to education. Not nearly so much about how to think.
Right. Yes. I see. Yeah. And it's an attempt to overcome the problems of diagnosing, which is a nightmare, I believe.
So in South Africa, you do a medical degree and then you specialize. So psychiatrists specialize in psychiatry, and orthodontists, or no, not orthodontists, orthopedics or surgeons or pediatrics. So is it the same in the States? So you do a basic medical degree and then you So what we call specialize. So it's quite a long course in terms of the years in South Africa. Takes about 10 years.
A traditional U.S. psychiatry education would be a total of 12 years.
Okay, that sounds
4 years undergraduate degree, 4 years of medical school, and 4 years of training in psychiatry.
Yeah.
And then if you want to subspecialize in child and adolescent psychiatry or geriatric psychiatry or any of these other subspecialties, it's an additional 1 to 3 years.
And you work mostly with pathologies. So a healthy person wouldn't come to you. You typically see people who, well, tell us, who do you see? And do they have delusions? Do they hallucinate? Are they addicted to substances? Do people come to you, or are they referred to you? Do they?
The joke that's running in my head is that if they don't have those things before they see me, they certainly do after. So I work for a government agency, the county health department, and I work in their behavioral health division. And so these are typically people who are low income and quite ill, whether that's with severe depression or bipolar disorder or schizophrenia. And with what I do, most of the people that I see have pretty overt psychosis. That is, they can't think straight, can't separate fantasy from reality, at least at some times. And so, yes, there's a lot of hallucinations, delusions, almost, well, to borrow from the old Masters and Johnson quote about sexuality, 99% of my patients use drugs or alcohol and 1% lie about it.
Yes. Well, it's interestingly, psychiatry is one of the younger specialisms in the field of medicine and science in general, I believe.
Well, I mean, if you go back to the late 1800s, there were quite a few neurologists who were specializing in behavior and thought rather than in seizures and brain damage. And these were probably the earliest psychiatrists. And in fact, the definitions of schizophrenia and bipolar disorder in many ways were an attempt to differentiate these patients from the other patients on the neurology ward who were having some similar symptoms as a result of tertiary syphilis.
Oh, yes, yes.
Okay.
And it was earlier manifestations of these conditions, because you can't see them physically, were attributed very often to, I don't know, witchcraft or demons or something. That's
oh,
the
sure.
case. Yeah.
Throughout the centuries, people have attributed what now looks like schizophrenia or bipolar disorder to all kinds of things. Of course, there were the unbalanced humors, religious ideas. If you look in religious texts, a lot of the prophets who had unusual thoughts or visions or behaviors, to me, look very much like schizophrenia or bipolar disorder with psychotic features. That it was episodic and they would go in and out. Even the oracle at Delphi, from what little I've read, there may well have been toxic gas exposure.
Yes, I've read that too. Yes.
Well, you just have to read the book of Revelations to that's the obvious one. I mean, just read Revelations and it's like, what was wrong? Something is wrong.
Yes. Well, this leads nicely into your journey from faith, Scott. Would you be willing to tell us a bit about that?
If I wasn't, you probably wouldn't have me on. I grew up in a suburban town in New Jersey in the United States. A very quiet town, but a bit progressive for the area. And my parents and I belong to a Presbyterian church. And you probably know more about Presbyterians in the UK than most Americans know about it. Here, I think of it as only one step more conservative than Unitarians. It was very liberal. We were very probably the first church within 20 or 30 miles that had a female minister.
Quite progressive.
It was. And so it was fairly easy to get along. There weren't a lot of proscriptions. There weren't really a lot of rules. The sermons were much more about how to have a relationship with God/Jesus than about what you should or shouldn't do. And it was more about philosophy and how to think. And my minister did have a doctorate in divinity. Whether that's, we can certainly discuss whether that's really a study, but at least, he had a fair amount of a rigorous academic thought.
Yeah, he put the effort in. Yeah, you're right. We could talk about whether theology ought to be a university discipline, but that's for another day, I think, maybe.
Right.
So you mentioned that the imbalance of humours back in the days of not knowing what was going on inside the head or in these people suffering from these conditions. That's an idea that hung on, isn't it, until reasonably recently. The idea that there was a chemical imbalance, too much or too little dopamine or serotonin or something.
Right. I actually see that idea of an imbalance of humors carrying on with exactly what you were saying. The people portraying what we know about neurotransmitters and neurons as if it was an imbalance in a chemical level. The same way that you might have a deficiency of vitamin D, thinking that depression is based on a deficiency of serotonin. And certainly even in schizophrenia, up until easily the 1980s, if not 1990s, a lot of people talked about schizophrenia as being too much dopamine, or at least too much dopamine activity. And I still see that cropping up in the way that psychiatrists just talk casually to each other.
Really?
So that idea continues.
John?
Go ahead.
I watched a documentary, John, I don't recall the doctor's name, about the DSM, and there's actually it was quite critical of the DSM. And am I right, Scott, if I say that we actually don't have a way to measure the levels of those neurotransmitters, because you can't just do a blood test? Am I correct in saying that, or am I completely?
Yes. No, you're correct in saying that. In fact, sometimes my patients will ask, well, why does it seem so difficult to get an accurate diagnosis? Why have I spent 10 years going to see 20 different psychiatrists, and I seem to get a different diagnosis from each one? And I explained to them that we don't have a test that will definitively identify whether or not you have schizophrenia or bipolar disorder or whatever. And when they ask me why, I tell them that it's because most of my patients are much too selfish to allow me to take their brain out and slice it up and measure the levels. And I'll tell you, even the schizophrenic patients usually do chuckle at that. They get the idea.
They get the idea.
It's very inconsiderate of them not letting you probe about with their brain, I think. But you've used bipolar and schizophrenia as though they are alternatives. Are they words that overlap, or is there some actual difference?
Well, yes, there is certainly a difference, but many of the symptoms overlap. And because most patients, certainly the indigent patients in the United States, end up switching psychiatrists, having to change from one psychiatrist to another for a whole host of reasons. They have to switch so often that the psychiatrists very often have only a glimpse of the patient's symptoms and history and longevity, such that schizophrenia and bipolar disorder are very often, those diagnoses are dependent on what the psychiatrist is seeing at any one particular moment or months or even a year or two in time.
Interesting, because I know at least one comedian who is fearful that he's becoming bipolar, and of course you wouldn't be the first comedian to have gone that way. And I'm wondering how much of this is environmental. You know, a comedian's life is very weird. They spend all day on a train alone, and then in the evening they have an adulating audience, and they go hyper to please the audience. Is that going to reflect on their stability?
Well, certainly your environment does indeed have an effect on everything about you. And your thought, your brain function is no different in that regard. If somebody said your environment has no effect on your gastrointestinal system or your respiratory system, that person would be laughed out of the room.
Yes.
And so the idea that your environment, even if you choose it, your environment has certainly an effect on your brain function, no doubt about it. Now, our most current thinking, and it's been this way for a long time now, is that diseases like schizophrenia and bipolar disorder are not dictated by your environment, but they can certainly be affected by it. And so if you are bound to end up with a bipolar disorder or schizophrenia, your environment, your history, your traumas may well bring that out sooner or later than it otherwise would have, but it's unlikely to change the eventual emergence of this disorder.
Scott, I want to ask you about diagnoses, and that leads me to what I'm convinced that most of the medical sciences are actually far less precise and exact than we presume.
Correct.
Because the more I learn, and I'm not a doctor, I'm just a very curious English teacher. But I do read a lot, and I love my documentaries, and the more I learn, the more I think that we think that medicine is an exact science. And I'm talking about physical medicine. I'm not even talking about psychiatry, what happens inside the brain. And good doctors that I've listened to are not afraid to admit that. And so what I want to ask is, do you think that naming things, naming diseases, diagnosing diseases, make it more prevalent? I'm asking this in particular because I watched that talk about the DSM, and I'm currently reading Charles Dickens' book, David Copperfield, again, after watching the latest adaptation on the airplane, on the flight. And what strikes me is that many of his descriptions of characters remind me of people who would probably be diagnosed with schizophrenia or bipolar disease or sadism or psychosis or you know, when you have, not sadism, the words, it's
Sorry.
gone now. And the fact that we now have a diagnosis, we call it psychosis or we call it bipolar, and suddenly every second person is bipolar. Surely it can't be that 100 years ago nobody was bipolar, and or 200 years ago. So how has naming things influenced how we see psychiatry?
Can I just interpose here, because DSM has been mentioned a couple of times, and I think we ought to explain to the audience.
Oh, yes, sorry.
It's not the directory of sadomasochism.
Nor is it a drug.
So, Scott, can you tell us what it is?
Well, thinking that it was the directory of sadomasochism is what led me into the field, but no.
You didn't think it was LSD? You didn't get confused with LSD and DSM sort of?
DMT, no.
Not that, okay.
So the DSM is the Diagnostic and Statistical Manual of Mental Disorders. And it's published by the American Psychiatric Association.
Mm-hmm.
And this lists all of the currently accepted and evidenced diagnoses, and also a list of potential diagnoses that are being investigated, so that those should be it should be on your mind when you're diagnosing a patient. And then it also has a list of other conditions that may be of interest to someone treating a patient that are not identifiable as diseases or conditions themselves, but are worthy of attention by the clinician. So, for instance, one of those is side effects that are directly resulting from psychiatric medications.
Interesting.
So that is, it is codable, and dealing with it is billable, which of course is very important to the broken U.S. healthcare system.
Absolutely, especially in your litigious country.
Scott, so I just want to say to the members of the audience who might not be familiar, I've always wondered about the DSM. So the first time I learned about the DSM was when I saw a psychiatrist myself for some, what I now believe is mild anxiety, but it was not so mild at that time. And even at that time, because I asked my psychiatrist, I said, can I have a look at this? And I looked at it. And then I was quite curious about some of the names and some of the diagnoses. And then I did a little bit of reading, and I learned that there was a time when homosexuality was actually a condition in the DSM. And that made me think maybe the DSM shouldn't be the Bible that it is sometimes treated as. Well, do you think... how do you see the DSM, for example? Like you say, I mean, I can see that there has to be sort of, it's sort of like a standards document. Am I right? Where you say this, and I can see that there's a need for that. Otherwise, you might get people who do lobotomies for free because they think it will, like lobotomies. Am I right in saying that? Oh, for the audience, a lobotomy, there might be those who don't know, is when they split your brain. Is it they split the connection between the two lobes of the brain?
No. I mean,
okay.
it has something to do with disrupting the connections, but it's not about disrupting or cutting what you're describing as the corpus callosum, the big cable of connections between your right hemisphere and left hemisphere of your brain. So in a prefrontal lobotomy, and that helps you orient to where we're talking about. It is the area just behind the eyeballs. And what's done there are various different ways of accomplishing it, but basically it comes down to mixing up, almost the way you would mix up baking ingredients in a bowl, but mixing up a very small area right behind the eyeballs. And this disrupts those connections, very small connections, not the giant cable between the left and right.
Okay.
And this disrupts in many ways, it disrupts or separates the thought from emotion.
Uh-huh.
Now, it doesn't reliably do that. We don't use this anymore anywhere for anything. But back before the days of any psychiatric medicines at all, it was in fact one of the only ways to reduce agitated psychotic behavior, where people would be slamming their head into the wall, biting their fingers off, attacking everybody that they see.
Yeah.
And so the prefrontal lobotomy was one of the few ways of literally unchaining these people.
Yeah. From their own behavior.
From their own behavior.
And then, of course, it got misused. And the famous example is a Dr. Freeman, who developed a very simple and effective technique for doing this in the office. And many of his clients at that time, which I think was the early 50s,
yes,
were children who were misbehaving, at least according to the parents.
Yeah. This is pre-Richard.
So parents would bring them in and say, he's just incorrigible, he's constantly getting in trouble, and he's going to end up, as a criminal on the streets if we don't do something, which of course was almost always a horrible exaggeration by the parents.
Yes.
But he would sit them down, do this procedure, which takes only a couple of minutes, and their behavior would in fact be reduced overall.
Yes.
And so, yes, to the parents who thought that this was an incorrigible child, this seemed like an improvement.
Yes.
But in fact, it was basically just a form of sedation.
So it wasn't surgical then. It was done in the office, as you said.
Well, there are surgical procedures done in the office now.
Am I right? If it's the person that I'm thinking of, I remember reading somewhere that he developed a tool that looks a little bit like an ice pick, and he would just go sort of behind the eyeball and just do the scrambling, and then
That's right.
And it was, I think he set a record for doing something like, I'm going to thumbsuck, but doing like 20 of them in the space of 3 hours. Am I right?
More like 50 a day.
Wow.
Something like, I didn't want to exaggerate. So which is a scary.
Yes, the tool, you've seen a tool very, very much like this in your dentist office, which is why I don't go.
Sorry,
But
John, am I allowed to drink?
The dentist has a tool that is metal and has a small bend about 1 inch from the end. And they use this to test the depth of cavities or to check how far away from your tooth your gums have receded, these kinds of things.
Yeah.
And it has a blunt end.
Mm.
It does not poke a hole in your gums when he touches you, right?
Mm.
And so, yes, he developed a method. It is surgical in that there is something being disrupted to your body in the office. And, you know, when my primary care doctor, my family practice doctor, removes a mole and sends it off for biopsy, that is a surgical procedure in the office. No big deal, but it's a minor surgical procedure. And that was also true for this form of prefrontal lobotomy that he developed. So he used this little tool.
Through the tear duct or something?
Yes, he actually, if you go in right at the junction between your nose and your eyeball. With this tool, he simply pushes the eyeball aside, does not disrupt the eyeball at all, and gets to the back of the eyeball where the skull is very, very, very thin. And then he would literally tap this, a small tap with a small hammer. And it really is not very painful or anything. You don't have a lot of pain receptors there.
Don't try this at home, folks. Don't try this.
That's right. You'll be taking business away from me.
Scott, sorry.
But then he would simply twist this tool, and because of the hook at the end, it would disrupt the connections between these cells and the rest of the brain.
Well, the earlier, more complete surgical cutting through the cranium, the skull, forms of lobotomy where the corpus callosum was severed. We learned a lot from that, didn't we? I mean, we learned how the brain
but
worked.
that was never severing the corpus callosum.
No?
This was in the same area of the brain, right behind the eyeballs.
Oh, okay. But I have a dim recollection of people being not just personality altered, but unable to write, or having one hand for one purpose and another hand wasn't aware of what was that about?
That's okay. A bunch of different psychiatry historical topics here. So there is a procedure to cut the corpus callosum. It's not used for this kind of disorder, and very rarely used, and I don't know if anybody uses it anymore, but this is a neurosurgery procedure, and it was used only in the worst cases of completely intractable seizures.
Epilepsy, in other words.
I beg your pardon?
Epilepsy.
Yes, epilepsy. And the problem with epilepsy is that no matter where the seizure begins, the altered neurological function, the altered electrical function, no matter where it begins, it tends to spread. And if it takes over the whole brain, then you get the whole body caught up in these episodes of these alternating, very rapidly changing moments of either violent shaking or complete stiffness. And this is what's called a tonic-clonic seizure. The classic somebody falls down and shaking seizure. And if a patient had just completely intractable seizures, it was ruining their life, causing further and further damage to the brain, and medications were of little or no value, then cutting the corpus callosum was a last-ditch effort to keep those seizures to one side or the other. And so it simply prevented the spread of the seizure to the entire body.
So what we're talking about here is really ancient history, isn't it? So these techniques aren't employed very much, or if at all, today. And I mean, we could go back to the Stone Age man's attempts to let the devil out of the head by trepanning. But there's a couple of interesting spin-offs from this that I want to delve into a bit. One is, I meant to start the interview with this question, really, but we can put it in now. We're assuming, aren't we, that you're not a brain-mind dualist. You don't think that the mind is a separate and spiritual entity from the brain. You think, like I do, that it's what the brain does, in the same way as a muscle contracts, the brain does the mind.
Yes, I would not say that that's true of all psychiatrists by any stretch of the imagination, but you're absolutely right about my thinking. To me, mind is just a sort of mystical and poorly defined way of describing thought and behavior.
Yeah.
And your brain really doesn't differentiate thought or behavior. These are both actions that the neurons produce.
Mm.
And in the same way that there's nothing mystical about the word digestion, it is simply our shorthand for the function of the digestive organs.
Yeah.
Movement is just a shorthand for the coordinated function of muscles against bones.
Yeah. Mm.
And yes, so I believe, whether you want to call it mind or consciousness or thought, that this is all just the function, the emergent function of the brain organs. Now you'll notice I'm using plural when I say brain organs, and we think of brain as one organ. But when you look at the different functions and the way that different parts of the brain have to coordinate to produce any particular function, what you've really got is a whole series of central nervous system organs that have been mashed together in a very small space inside the skull. But if you separated them out by a little bit more distance, they would look very much like the digestive organs that are very easy to separate and say, well, this one does these one or two or three functions.
The stomach, the spleen. I've been learning. I've been teaching myself a lot about the brain because the brain fascinates me as a teacher. Because what I'm actually doing as a teacher is trying to work with, in many ways, teachers and Sorry, John.
Other brains.
Yes, I'm trying to change children's brains by changing, doing things, but not. Well, sometimes one does feel like just taking a crochet hook and sticking it in there, even with my own. But Scott, what you said now, I would like to circle back to the work that you do with indigent people, but this ties in with the whole thing about the mind dualism, because religion, and this brings the whole question of religion into the discussion of psychiatry, because from a religious point of view, you have good and bad, you have evil and benign, which are concepts that I think are redundant and that we don't need. In my opinion, you have brains that are functioning relatively well in the environment that they have to function in, and then you have brains that are not functioning well. That's maybe a very oversimplified version of it, and that brings me to the whole idea of addiction and substances. And I would like to hear what you think about this. So many indigent people in South Africa, and I've actually gone out of my way to talk to them and interview them, and I have some very interesting conversations. And because in wintertime in Worcester it's cold, and these people sleep on the square, on the town square, because it's relatively protected. And I love to talk to them and talk to them about their lives, and most of them are addicted to many to LSD. They all use cannabis, and somehow they find a way to get their fix. And I was actually thinking, so addiction is labeled as bad behavior, and being a drug addict is labeled as bad, and it's a criminal offense in South Africa. And I've wondered, especially after watching the documentary on Netflix based on the book by Michael Pollan, How to Change Your Mind: The New Science of Psychedelics. I'm not sure if anybody's familiar with that. Are you familiar with that, Scott?
I think I've seen some excerpts. I'm certainly familiar with Michael Pollan.
Yeah, so the documentary is based on his book, How to Change Your Mind: The New Science of Psychedelics. And I was talking to one of the indigent people in my hometown, and I asked him, so what are you addicted to? And he said, no, LSD. And I said, so how much do you use a day? And he said, well, if he gets half a tablet, then he's fine. And the reason he's on the street is because using LSD is illegal. So it was criminalized. I mean, obviously he's been on the streets for 5 years, but he used to have a job, and he's perfectly, I mean, he's more rational than some people I've worked with.
Right.
Mentioning no names.
Absolutely not. Well, so what's your experience with the connection between drug abuse or drugs? I don't want to even say drug abuse, drugs and indigent people, and the way that the moralization of religious type thinking has moralized things that shouldn't be. It's not a moral issue. It's not an evil, benign issue. So I've said a lot. So what's your opinion on that?
Well, you're certainly right that various behaviors have been moralized, and then the morality that's presumed has then been pathologized to be a condition worthy of treatment, even if you need to be locked up against your will to accomplish that. No question, that's true of lots of different things throughout history. You mentioned homosexuality previously, and that went through the exact same thing. At least in the US, we may be seeing a resurgence of that idea. All sorts of behaviors, even what we would now, most of us would think of normal sexuality, was moralized and then pathologized within the last 150 years. And at least in the US, I don't know anything about the UK in this regard, but at least in the US, 80 to 100 years ago, a husband could commit his wife to a psychiatric hospital, in other words, have her admitted against her will and held there against her will, for almost anything that the local society considered unusual for a wife's behavior, whether that was refusing sex or wanting more sex than the husband does, or wanting to go to work, those kinds of things.
Wearing pants.
In the US.
Yes.
In the UK, I think too. If you just have to read The Women in White by Wilkie Collins. If I just reread The Women in White. I mean, people were institutionalized for just drawing odd pictures. You could be institutionalized. Women especially, and their uterus, and they were given hysterectomies because it was their uterus that made them mad.
Yes.
That explains.
Yeah.
That explains me.
And shamefully, of course, homosexuality was punishable right up until when I think it might have been the early 1960s in the UK. And of course, Alan Turing was medicated shamefully and took his own life. Yeah. So something's happened, hasn't there, from the early sort of barbaric and ignorant treatments that were enforced on people to the modern sort of psychiatry and neuroscience, where somehow we've discovered some psychoactive substances which actually do work. I mean, lithium is a boon, isn't it? So how did that transition occur? What's gone on?
Well, of course, when you start to find treatments that work, it's then much harder to moralize about this. Once you have a treatment that obviously has no moral value in one direction or another, a chemical like lithium, which is just part of the periodic table of elements.
Yeah.
Once this actually accomplishes changing the problematic thoughts and behavior, then it becomes very difficult to identify either the behavior itself as a moral issue And certainly it becomes difficult to identify supernatural entities as the cause of the illness. You know, if you're trying to tell me that demons or gods caused a person's bipolar disorder, then it's very difficult to explain why an element found in the dirt throughout the globe can remove the supernatural entities. Yes,
indeed. Yeah. So we've got some interesting comments coming up in the chat here, because we've got this one. Religious belief, is it a mental disorder? I know this is something which has been considered as a reason to add to the DSM a couple of times, and I don't know what state it's in at the moment, but can you bring us up to speed on that, Scott?
Sure. Well, a delusion is a symptom, and a delusion is defined as a fixed false belief that is not amenable to evidence to the contrary. And so the typical kinds of delusions that we see in psychiatry might be a patient who says, I am God, or I am Satan, or I am the president, or some of my favorites over the years were that all diseases result from bacteria in the soil, and so if we simply paved over all of the open soil on the planet, all disorders, all diseases would disappear.
Or use drink bleach to prevent COVID. Did you ever come across that one?
Right. Now, you know, I think most of the people who have attempted that kind of thing in the last 2 years are in most ways they are uneducated, and not that they have a fixed false belief that is not amenable to new information. Typically when they start coughing, they begin to rethink this.
Okay. Yeah. I do think, just to answer my answer to the bearded heretics question, I would be very careful to diagnose religious belief as a mental disorder, purely because I think that there's so many other factors that play a role in religious belief, and I do think that it's definitely something to keep an eye on, but I would be very, very careful to say that religious people are delusional, because that would mean that I was delusional for the first 40 years of my life, and I certainly didn't think that I was. And we might, so I would just be careful, purely because there's so many other factors that play a role in religious belief and how people express religious belief. But there are definitely there is a case to be made for certain expressions of religious belief to be very dangerous and might lead to serious delusions. And I do thank you, bearded heretic. And I also am convinced that religious belief can be a major contribution to serious psychiatric disorders. What do you think about that, Scott?
Yes, I think most all of that is accurate. So I described what a delusion is. Now, to have a delusional disorder where it is a pathology requiring treatment, the delusion has to negatively affect almost all areas of your life, where it is producing distress or dysfunction in almost all areas. And so the fact that somebody might believe that there's a civilization that is simply hidden from us on Mars, if that doesn't affect the rest of their life, then it's not a disorder.
Uh-huh.
Now, and with religion, most people that you see walking around, I would argue they behave in an atheist manner 99% of their life.
Yep.
As they walk around, as they function in a grocery store, almost all the behaviors at the intersection of roads, people are behaving in an atheist manner. They are not behaving according to their religious beliefs.
Yep.
And so I would have a hard time classifying it as a form of delusional disorder, except in some very extreme circumstances, in the same way that if somebody was convinced of a hidden civilization on Mars, and in order to get attention, they were setting off bombs at public buildings across the country, now we've got a disorder.
Yeah.
Well, in that vein, I've spoken to several people. I've interviewed a lot of people, and I've spoken to a couple of people who think they have got a variation of PTSD as a result of an extremely fundamentalist religious upbringing, which they've struggled to escape from. What do you think about that?
Oh, absolutely. The forms of trauma that can result from certain kinds of religious upbringing and religious services and religious ceremonies can take all kinds of forms. We see people, this last week on the internet, I saw a picture that, if it's real and if the description is correct, was two young adults having intercourse on what you might call the stage of a church, being led by a preacher and the congregation watching in order to bless their intercourse into resulting in a pregnancy.
That sounds like something that happens in Nigeria.
And I honestly don't know where this supposedly took place, except that my memory of the picture is that the couple having intercourse under a blanket, you could see both of their heads, and I believe they were both Caucasian, but that doesn't mean they weren't in Africa.
But Scott, and John, I can't see that there's any dispute about religious exposure causing some form of PTSD to different people, because religious exposure is something that happens to us, and it's part of our environment, and anything in anybody's environment can cause PTSD type symptoms. And something that I think we lose sight of is that we are very complex. Something that is a trauma to me might not be a traumatic experience to the next person. So I can't see how even religious people can dispute the fact that some people can be harmed psychologically and by religious experiences. To me, just purely on the basis of that, your environment and what happens to you, your experiences can have very negative impacts on you, but that also depends on your brain profile and your personality and who you are and the experience, of course. So
we're coming up to, sorry Tercia, but
no,
we've only got 5 minutes left of our hour, and I've got teenagers, and you've had teenagers, Tercia.
I still have one.
You still got one, right?
Yes.
Something goes on inside the teenage brain, doesn't it? They change in time.
Nothing. I think nothing goes on there.
Well, that's very unkind. I'll tell your children you said that.
No, I'm just joking.
I'm just wondering what Scott can tell us about that.
Well, my father told me many, many times that adolescence is a terminal condition because it's going to kill one of us.
Yeah, the child.
But yes, the changes that take place in the adolescent brain. There's a whole variety of them. You've certainly been exposed to ideas about like Piaget's stages of development in a child. In the adolescent, there's a psychosocial change going on where they are no longer that interested in what the authority figures want or think.
Yeah.
And they are differentiating from their parents and their parents' society.
Yep.
They become much more dependent on peers for what to think, what to do, what's reasonable, what's fun. And they're also just barely beginning to be able to have their own thoughts about the medium or long-term consequences of their behavior.
Yeah.
As an 8-year-old, you knew that something was dangerous and you shouldn't do it because your parents told you so.
Yeah.
And as a 15-year-old, you've decided that nobody over the age of 25 ever knew anything.
Yes.
And you have to find out for yourself.
Yes.
And in most cases, it's not until around mid-20s that the frontal lobes, where we have our ability to make judgments and understand long-term consequences, and think through whether this is something I really want to do or not. It's not until our early to mid-20s that fully develops. And so during this period of late adolescence, whether the government puts the difference between adolescence and adulthood at the age of 18 or not, the biology suggests that this goes on until early to mid-20s. And I think a lot of us can look back on our own lives or the lives of our kids, our friends, and see this as true.
Scott?
Yes.
Scott and John, this is one area where, when it comes to teenagers and teenage behavior, it's one area where I'm really, really critical of the influence of religion, because South Africa is a lot like the United States in that respect. Kids are indoctrinated with religion, and my hypothesis is that most schools do that in an attempt to curb the erratic nature and the risk-taking behavior of teenagers. But instead of teaching teenagers what's going on in your brain, what the changes are, they're trying to say, don't do drugs because Jesus will see you. Don't masturbate because it's a sin. Don't have sex because it's a sin. And so in the first place, it has no effect on the kids' behavior. It just contributes to making them now feel guilty on top of everything. And I think that is where a lot of religious trauma originates, in the teenage years, when religion is used as a tool to try and get the teenager to conform and not go through these stages. And I think in the UK, it's not as bad, I think, but in South Africa and in the United States, it's particularly bad. And that's one of the things that I'm trying to be an activist for. But John, I will keep quiet now because I see we've got 30 seconds.
Well,
So
we've got seconds to go. And I just want to say that next week we have another interesting guest whose name is Alan Cartwright, and he's a Christian clergyman here in England, somewhere further north. I'm on the south coast, so it must be further north than me. We're looking forward to having a conversation with him. I've known him for a while through interactions in Facebook, the Unbelievable group, where I think you and I met, Scott.
Yes, and you and I too.
Yes, John. Indeed. Yes, and we've also done messaging together, so we can communicate in a very. He's described me as wonderfully genial. Oh, I was so flattered.
Well, John,
that's a delusional disorder.
Thank you.
have been described in South Africa as the atheist with Jesus in her heart. So I don't know if you say that's delusional too. So
Yes. Well, I always tell people I'm not proud. I'll speak to anyone. Anyway, thank you very much, Scott. I think we'd like to have you back because we haven't touched on what Tertia just. Oh, she's that side. No, that side.
You're right.
We haven't touched on what the subject that Tertia was just broaching, which is how psychiatry and psychology are being taught, because that's quite contentious, I think, and especially as it's sort of in competition now with the offspring neuroscience, which I've interviewed several neuroscientists before, so we could, if you're willing, we could invite you back. Oh, great, excellent. Well, thank you very much, and thank you, viewers, both present and future, when it becomes a podcast. Look forward to seeing you next week. Say goodbye, everyone.
Bye.